So as people are coming in, I'm just going to introduce myself here. I'm Larry Mroz. I'm the Research Services Lead for the BC Support Unit, and I'm also the Patient Engagement Coordinator for the Vancouver Centre. And I'm really happy to have you here today. I live and work in Vancouver, and very pleased to have you at this breakout session today. There are, I think, 4 or 5 other sessions going on right now at the same time. And this session is Learning, Unlearning, and Relearning Patient-Oriented Research panel discussion. Just in case you're wondering which panel you're in or which breakout session you're in. And just to let you know that we will be recording the session, and you're invited to turn your cameras on if you wish. I believe that option is available to you. So feel free to do that if you want, but you're not obviously obliged to do that. We do have a question and answer capability here through the chat, so please feel free to put any questions into your chat. So I'd like to introduce our panelists today. We have Karen Maywald, we have Barbara Kroom, we have Davina Banner, and we have Marilyn Parker, and their bios are on the conference website, and I think they'll probably want to introduce themselves. And I think on that note, I think we are ready to go, and Davina is going to be the moderator for this panel. So welcome, panelists.
Perfect. I see we have a few more in the waiting list, room 2. So as people are joining us, welcome. So good morning. My name's Davina Banner. I'm based in beautiful Prince George, which is on the traditional and ancestral territories of the Lheidli T'enneh, which I'm very grateful to live and work here. A little bit about me. I'm a researcher based at UMBC, and I have a special interest in patient engagement and integrated knowledge translation. I'm thrilled to come in today and moderate this session. I'm also a mom of 3 and a cheese eater, which has not gone so well over COVID because I've had more opportunities for cheese eating. So there we go. So our panel today is focused on learning, unlearning, and relearning together through patient-oriented research. And we have a fabulous panel who will be introducing themselves shortly. And so we know as patient-oriented research has grown, it's really provided some great opportunities to foster research that best responds to the needs, the values, and priorities of patients and communities. And that there's also alongside that been an increasing focus on how we engage in patient-oriented research in the best way possible. And so today we're going to have some great stories from our presenters about their own experiences of engaging in patient-oriented research. And so as we go, we do encourage you to ask questions. So please do use the chat function, and myself and Larry will be keeping an eye on that. So first of all, I'm going to ask our esteemed panel members here to introduce themselves, and I'm going to head firstly over to Marilyn to introduce yourself.
Good morning, everybody. First of all, my name is Marilyn Parker, and I would like to acknowledge that I live within the ancestral, traditional, and unceded territory of the Syilx Okanagan Nation. I reside in Kelowna. And it's just a pleasure to be here. I was parachuted in yesterday, so I hope you'll bear with me. Thank you.
And to Karen.
Thanks, Davina. My name is Karen Maywald, and I'm with the BC Support Unit's Interior Regional Centre based in Nelson. I'd like to acknowledge I am joining you from the ancestral, traditional, and unceded territory of the Syilx T'enneh and the Sneaks Nation. I'm located in Nelson.
Great. And then to Barbara, please.
Good morning, I'm Barbara Kroom, and I'm here with Davina in Prince George. It's been my home for almost 20 years from the Lower Mainland, and I'm very grateful to be part of this Putting Patients First and Learning and Unlearning, and looking forward to the discussion that's going to happen.
That's fabulous. So as I said, our panel this morning will be some storytelling about experiences, but then we do encourage you as you go to jump in and ask questions. And so our first point of call will be Marilyn, who's going to talk about her experiences and her partnerships across the province and across Canada. So Marilyn, I'll hand over to you.
Thank you so much, Davina. So thank you to Karen as well for the opportunity to come and share with you all today. I like to share as often as I can. I'm currently on about 4 research projects. One actually is interprovincial, UBC, McGill. And when I first became a patient partner, I soon realized that research was embedded in everything we did. So that research team was the first one I joined. We are now in our 4th year and finishing off the 4th year and writing papers, which is another learning for me as a patient partner. I'm blessed to have an adjunct prof from UBC living in Ottawa now that's helping me out. So one of my first experiences was in December of 18. I was invited on behalf of the BC Primary Care Research Network Patient Advisory, of which I'm a member, to attend this session as one of 12 patient partners across the country. My biggest learning from that session was, first of all, I have a voice and I use my voice as often and wherever I can. But my biggest learning from that was we had a physician at the end that stood up and said, I see no reason when I first saw this conference why patients should be involved. After today and the day prior, I have completely changed my attitude and I fully will engage with patient partners. So that was so moving and such a learning for me. Also, I am a member of the BC Support Unit, and part of that group, I was invited to sit on the training capacity development, where we actually produced 2 webinars this year on grant funding applications. One from the patient partner perspective and how to be involved, and the other from the researcher's perspective. So I encourage you to look on the BC Support site and you will find those videos. I've also done a video for SPORE speaking about the importance for patient partners to share their voices. And I currently have one video in the process, in the tube for Interior Health, which I also encourage more patient partners to sign up. I've been very fortunate through my peer group. I have spoke at both UBCO and TRU, which is the university in Kamloops. And I have been able to speak directly to researchers and students who are completing their BAs or their PhDs. And basically what the first group with the UBCO was, we speak to the MRF group. It's a newly formed group. They look at qualitative and quantitative research, but also mixed methods. And I do now understand all of those because I've had to utilize them myself. And really what we spoke about was the value of partnering with patients and how they gain in not only the breadth of their knowledge, but the depth of the knowledge they gain from patients' lived experiences. I also am a member of PEER, which is Karen's group. And we actually started forming late 16. I joined in 17. And we've gone through the regular forming, storming, and norming. And we are now, I believe, a highly functional group. Just about every one of us are involved in some way or another in our communities and provincially. And basically our group, my part in this group has to be to reach out to people in the community. So I've spoke to retirees groups, I've talked at the library. It to me, the value is connecting researchers and patient partners and having both of them understand the value this brings to the end result in research. And really, bottom line is, I also see my role in PEER as supporting my other team members. So I'm looking forward to hearing from Barbara as well, and we'll see how the progress goes with your questions. So thank you.
Thank you so much. And I placed a link in the chat box there for the Patient Engagement in Research Committee. There's a one-pager there, so feel free to check that out. So we're inviting some questions. So if anyone has a question for Marilyn, please jump in. But in the meantime, I was curious, and I was thinking, you've had so much experience across BC and across Canada. What do you think researchers really need to learn in order to have meaningful partnerships with patients and the public?
You know, there's so much, Davina, when I look at this. Really, the main thing that they need to learn is the benefits. When you look at selling any product, you have to reach out to those you sell by benefits and say, this is what you'll gain. So first of all, they gain from multiple perspectives that they may not have had before. They also gain from those lived experiences. Again, that's where I spoke about the depth of their results. And not only, as I've mentioned, the breadth, but they gain synergy in the collaboration with patient partners. And by synergy, I mean that just there's so much richness that comes from sharing and learning, you know, what we do bring. And recently, when I was at the PPF20 conference in December of 18, when Dr. Tom Noseworthy closed off in the conference, I love what he said. He said, patients are the North Star of research. And so for me, when I reach out to researchers, that's really the message that I want to share, is that we really help to point them in the direction of those maximized results.
That's great.
So Marilyn, it's Barbara. I'm just sitting here in awe of you, and can feel like I can learn so much from your experience in all your different research groups. What do you feel is the benefit for the patients?
Well, first of all, I believe in continuous learning, and you can tell there's a little bit of gray here. So I've been on that journey all my life in whatever way that is. I think the benefit for me, the biggest benefit is having a voice and utilizing that voice and just sharing and being able to tell people this is a journey that we're on. When I'm asked why I do this, myself and my children have benefited immensely from our healthcare system. But I want to know that this system is here for my children and my great-grandson. And so really that's my motivator behind everything that I do.
That's fabulous. Thank you so much. And so we're not seeing any questions, so we're going to move on now. So our next presenter will be Karen, who's going to talk about her experience as a researcher and her experience of working in partnership with lots of different teams. So Karen, take the floor.
Wow, thanks Davina, and thanks Marilyn. I kind of just want to sit here and continue to listen, which is where I'm more comfortable. But here I am, and I have 5 to 8 minutes, and I'll try to make the best use of the time that I've been given to talk about with you today about the project that I embarked on as an embedded scholar. So this project was tagged as a postdoctoral study as an embedded scholar within the interior health system. And I also want to talk with you a little bit about today about some of the lessons that I learned, listening and reflecting and responding, the difficulties that I encountered myself and what I had to unlearn as well. Hopefully we have enough time for that, and I really welcome questions. If you can share them in the chat box, I won't look at them now. Before I begin, I would like to acknowledge the tremendous work and the lessons that I've learned from and working with Alison Kooijman as a patient co-partner on the research team. Also the lessons I've learned and working with Paul Bergener, who helped tremendously with the idea of mapping concept, of mapping patient engagement across the interior center. We used data from Patient Voice Network. we used from 2016 back to as far as we could to really produce a mapping where we could see where engagement activity was happening. Also, we used administrative data from our research department where we could see patient-oriented research and patient engagement was happening. The map is in development, but it gives a visual image. I'm not sharing it today, but it's available. It gives a visual image of where patient engagement activity is taking place and where we could really see the corridor of Kelowna, Penticton, and just little bits of really amazing activity. For example, Williams Lake, activity in Nelson, some in the east, but also still how urban centric still the engagement is taking place, where one of our priorities are to help rural development and engage rural populations. I'd like to acknowledge the work of my supervisor, Dr. D. Taylor, and my mentor for years, Agnes Meershoek, Maastricht University. My patient engagement and research committee, I say it's not mine, we all own it together. The Patient Engagement Project was the name of the project I embarked on. We had an advisory council. All the participants that so kindly shared their experience working with researchers, working with patient partners, 34 interviews, and hours of learning, sitting in meetings, being attentive, listen to what was spoken, listen to what was shared, to get a better understanding of the opportunities and challenges that are happening within the engagement within the interior health system. Davina, Barbara, Maren, thank you for jumping in late, and Cleon for working on this panel abstract and discussion. I learned when I was preparing for patient engagement in the Interior Center, how the experiences of engaging in quality improvement initiatives could possibly affect the willingness to engage again in research projects. And what we then thought of was a study to do a deeper dive. What are the experiences of patients when they engage in quality initiatives? And what are the experiences of patients working with health professionals and researchers in patient-oriented research? But as well, we wanted to listen to health professionals and learn their experiences, as well as researchers, if they were so willing to share their experiences. So what I learned when we embarked on this in 2017, we secured first a grant with a postdoc scholar, but she was taken away from us and she went to Halifax. So I became then the postdoc researcher. Going through the ethics research process was about 7 months. To get access to speak to researchers, to get access to even go through the research process was a long, time-consuming process. In that time, I was able to build relationship with the Patient Voice Network, the patient engagement leaders in the interior region, the interior health patient engagement leader, Carla Workoch, and build a patient engagement project advisory council collaboratively with Alison. We interviewed people and thought about who would be really good helping us in the studies. The interviews, finding people that were willing to share and listen to them, and how we could possibly respond within the interior health system. They were saying all these things, and they were saying things that were not right right now. And at times it made me feel awful. On the other end, I was hearing stories. People were telling me how they work together with health professionals, how little things such as bringing new people to the table was important, how much they appreciated when people were seeing the importance of traditional territory acknowledgement. How we're asking simple questions that people really thought about, that they were able to make changes in, for example, provincial primary care policy development and mental health community programs. Those lessons that I learned and what I was hearing, these positive experiences, that was truly awesome and inspiring for me as an embedded scholar. What I also learned through the process is how I personally struggled as an embedded scholar working within interior health, hearing about the experiences of exclusion and discrimination. I heard about stressors of voices of domination, of fear and prejudice. I heard about inaccessibility to engage due to gatekeeping, poor public transportation, incomplete internet and cell coverage, and internet digital technologies, particularly in rural areas. I wasn't ready for this. I had no experience working through this. I found incredible mentorship through all the different people that I worked with to still tell that story. I didn't know how to present it to the VPs in interior health. I didn't know how to present it to my colleagues in Interior. I wasn't sure how to do about it either. I had to listen to these stories and I felt I had to respond, but I didn't know how to respond. I was given tools to prepare PowerPoint slides. I was given tools to write reports. I was given the tools to publish publications. Anyway, through much help and through many reflections and amazing people I spoke with, I learned that through very patient, and I mean patient, careful interpretation, I learned about ways in which I can help to make change, and it's listening and contribute to conversations. For example, by asking a careful question, tips I heard from patient partners. When working with interior health staff, try give some small kind feedback as encouragement, like a wayfinder. Sometimes it was just a matter of changing wording on a research project, on a research report or a poster. The joy of introducing people to each other, those who share a similar interest, that was really a positive experience. And what I really learned is to keep the patient voice central. All times, how difficult it can be for patient partners when they're in a room full of professionals to share their stories, to articulate their needs, their desires, and their wishes, and to really ensure that the voice is kept central. How am I doing for time, Davina?
Couple of minutes to wrap up, and we've got some questions for you.
Great, thank you. What I had to unlearn. I made a couple of notes on that when people have diverse perspectives and bringing knowledge together, it can take about 2 or 3 years. Sometimes it doesn't work. It doesn't work with very small timelines all the time. So trying to sometimes push through meeting a deadline can be really difficult when you already have established relationships. So I find that difficult. I think sometimes I need to learn that if an opportunity or a patient idea comes up with a very small timeline, to reflect on the relationship first, what it can do, perhaps by asking and inviting people. What I had to unlearn, I had to personally for myself as an embedded scholar, had to let go of the thought that writing a critical report to the organization was not going to make any difference. I felt most of the people that I work with are very aware of health inequities, exclusion, and discrimination. It's just that their ideas or possible solution might not be the same as mine or that of the public. I also learned to be not so hard on myself. I think I shared with you that I learned about ways in which I can contribute, and I'm very grateful that I'm still involved and that I can still be at meetings at local level, at provincial level. I meet new people all the time, and I really like to learn from others' experience as well. And I learned a lot from reading, and I like reading philosophy books. And I think it is really important that in patient engagement, for me, realization is not a fact that you approve of or disapprove. I think it's the wrong question to ask if it's proven that there is patient engagement. I think it's the possibility that people can speak and share ideas and experiences with each other to find shared solutions. Patient interpretation. Thank you.
Great, thank you so much. We have some questions, and they're great questions, and we also have a message from Stephanie to say that later on there'll be another panel presentation occurring at 2:30 where some of these issues will also be picked up. So we had a question from Marilyn. Marilyn, did you want to ask it, or do you want me to read it out?
I can ask it. Karen, during your survey, did you hear many patient partners speak about feeling marginalized?
Yes, I heard that. I heard those experiences, and I also learned that people perhaps had a little bit more difficulties making connections to contribute to a project in the interior, but they did find ways to find people to work at provincial level. So sometimes it was easier for them to work with people outside the interior system to help create change. And the marginalized people that I learned from were not only, like, we talk about marginalized indigenous populations, but I also heard marginalized populations in terms of single moms, people with mental health problems, people who are perhaps not able to articulate well their needs. And I also heard about perhaps being invited as in a community by for example, for quality improvement projects. But then really the project was already sort of at the end phase when they were invited in. And the disappointment when there was first excitement about being invited and that it was going to be a community activity. And then in the end, the experience that it was not a positive experience.
So just Karen, I'd love to share for researchers, you know, it's sometimes much better to have more than one patient partner involved because they can partner and they can share their experiences and they can encourage each other. And I think that helps to address people feeling marginalized.
Excellent.
Yeah.
Great points there. We also have another question too, and I think this is very timely given where we are in the world today. And so we had a couple of questions here from Patricia and Minnie, and they're kind of related. And they're asking about how we've seen teams kind of adapt to that virtual environment and supporting that process of engagement virtually in our world today, where we're obviously, you know, living in the reality of the COVID-19 pandemic and so forth. So I wonder if Karen or Marilyn want to comment a little bit about that.
Marilyn, I'm happy to speak to that. I think, you know, if I just very quickly, my experience has always been virtual online. We've since my involvement with the BC support units, we build and grow the Patient Engagement Research Committee, all being in different locations. The opportunity to collaborate virtual is not always easy. I miss the in-person connection just as much. I'd learned as a master student and a PhD student, and now completing my postdoc, I suppose, but as a health professional and as a decision maker within the interior health system, being rural, my work is online. My work is working through virtual technology. So the switch to it, there was not a switch, there was a continuation for us.
And Karen, if I can add, I think for patient partners, what researchers need to be extremely mindful of is maybe building into their costs the ability to maybe provide technical assistance, being computer, you know, an iPad, whatever that could be, because some patient partners may not have electronic access. So really, that's got to be the biggest bump for some people. And then the patients to help them learn this technology, because if you've not had those experiences before, the researcher really needs to be aware of supporting that learning curve as well as the research learning curve.
Okay, and Barbara actually has a follow-up question too.
Karen, just as I was listening to your experience, and from my experience as a patient, is it important for the patient to be understood, their health situation to be understood by the researchers, so that they can understand and make a space for that person?
I hope I understand your question correctly. So would they want to know, or would it be important that they know the medical diagnosis of the person? Yeah, personally, for me, if people are willing to share, that is helpful. I think what really helped in my experience as a researcher is that I worked for 18 years as a clinician, as a physiotherapist. I think I was well positioned, if I may, by listening to people, and I was able to integrate. You know, when you're used to working with people, to listen, and for me, the medical diagnosis doesn't mean what the person wants to share with me, and I think that's where prejudice perhaps. So delay a judgment. For me, that's really important as a professional and as a researcher and as a person, is to delay, because if somebody would tell me their diagnosis, then yeah, no, I find that difficult. For me, it's not, if the person wants to share it. What I did have to learn was get a better understanding of trauma-informed care, for sure. I think that was something that I learned, to learn about the principles of learning through, I did many courses on Indigenous reconciliation, much training online. I looked at everything I could get my hands on to learn and grow as a learner through online training, but as well trauma-informed, for sure. And personally also reflect on what was happening. If people was telling me a very difficult story that happened in their life, before I responded, first check in with myself. First really feel, where was I? Where was it possibly triggering me before I responded? So I think there was much to do, much internal work. For me, that was really this 2-year time frame. It was a difficult journey at times, but also a rewarding journey where I learned to reflect on also on internal work in order to respond hopefully better to what the people were saying. Does that make sense?
Yes, absolutely.
That's fantastic. Yeah.
Thank you.
Thank you so much. And so thank you so much. And we're going to move in that vein, I think, and talk a little bit more about relationship. And I'm super pleased to hand over to Barbara. And just before I do, I want to say that this incredible woman came into my life, I think, at a time for both of us, I think, where, things were very uncertain. And I think if I can say one thing that I have learned or relearned through the partnership, and I've learned so much personally and professionally, is that the opportunity to work with Barbara took me back to my 22-year-old self when I was finishing nursing school and feeling like I could help change the world, through work, and the hopefulness that comes back, and not to say too much about the academic environment, but anyone that knows me will know that, that road is often a bumpy one and full of ups and downs that can be very challenging at times. And I think for me, working alongside the many patients that I do, including Barbara and Mark and others, has restored a bit of faith in humanity, a faith in research, and a hope for the future that the world can change. And I say Barbara's been such an inspiration personally and professionally to me, and someone who I've just come to love so dearly in my life. And so I've seen Barbara stand up, work alongside health system leaders, healthcare providers, people that are kind of powerful in the research world, but I've also seen you stand and make your voice known so confidently. So I'm thrilled to hand over to Barbara today, and you're going to talk about kind of living with complex health conditions and being engaged in research.
Good morning, everyone. I am so grateful to be here as a patient partner. Just a little bit of background. I was a service provider to marginalized people before. I worked, I was in recovery for 30 years, and I worked with street people and in different service organizations. So 5 years ago, I had a sudden health crisis. I had a subarachnoid hemorrhage stroke watching my grandson play hockey. And it was December 29th at Christmas time. And I went to the hospital, and I had been a patient advocate. I had been on the other side working with the medical profession to help be the voice of the patient. When I was in that hospital, I couldn't have my voice because I now had a brain injury. And I got my best friend there, and they said I had a brain bleed. I had no idea what a brain bleed was. Then my friend said, there's something wrong with her, that she's not herself, because they wanted to send me home. I ended up going into another unit, which is just an overflow unit from the emergency unit. And from there, I knew I was in big trouble. And I had previously had wonderful health care and had run into amazing people in the health profession when I was an advocate. I found that there was nothing being offered to me. There was no information being offered to me because I had a history of drugs and alcohol 30 years ago. I was told I was chasing drugs, and I had the worst headache of my life. So I happened to have a best friend that I worked with who was in the brain injury group. And I called her from the hospital. I said, I'm in big trouble. I need help. And I immediately after getting discharged from the hospital, my doctor had been working well with the people down in Vancouver, but being up here scared the crap out of me, I gotta tell you. And so getting involved in the brain injury group gave me information. Information is what I needed to understand what happened to me and how to heal. But I had to continually seek out the healthcare that I needed. And that's very hard when you have a brain injury. I now had an invisible disability. And so that was, I saw a stroke study somewhere. I can't even remember where because I'm still living with
Diamonds, wasn't it?
Yeah, a Damon study. And I was so grateful that people were studying this because I really thought the medical situation here was terrible, that they didn't understand strokes. I was even told, who told you that you had a stroke? You had a brain bleed. Well, that's a stroke. And so the way I was even spoken to, I found was disenfranchising me from my experience and the medical help that I could get. So I had to turn this into, when I got with Damon and felt accepted and listened to. And then I ended up with, I don't know how Davina and I went on this mapping journey. It was so wonderful because she came into my point at a life because my life went right off the rails. My professional, I was in the middle of a master's program. My trajectory was just going, I didn't know where. And my life has to have purpose. So Davina and I went through this mapping of my story, and I just was visualizing things. I could only express myself through terms of my head exploded. I saw colors. My way of expressing myself changed. So this partnership kind of freaked her out a little bit because she's an academic and she, was, how do you write down those things, And so
the scary art. She kept bringing me art, and I was like, I can't draw a stick figure. Let alone anything else, wasn't it?
Yeah. And so we ended up co-leading an art-based study on stroke and brain injury. And that was so important because I'm coming to this research with a brain injury, which brought also on depression and anxiety. The biggest thing for me was that they understood these things for me and cared about it and tried to help me with that process and to feel included, not that I was lacking something, because after getting a brain injury, my experience in the world was quite devastating, actually. So we co-led these different patient engagement and how the different populations experience barriers and virtual health. I was doing my other work online, so doing this didn't affect me all that much, except for having a brain injury and flooding from what was going on sometimes on the screen. So these people that I work with were fabulous in helping me manage that. And when I said I'm flooding or I can't do anymore, it was accepted. So the trust and sharing that I have felt on this team has allowed me to go on, so that testimony and experience can help change the way that we are treated, because if decision makers don't have truth, which includes our voice, they can't make decisions that improve our care.
And I think that's great. And I think the thing I think building for me on the side of that partnership too was as a process of really critically thinking about safety and relationship. So building those safe spaces, not only between us, I think, but within a team, and modeling that through, and that meant everything, I think, from working together to really think about goals, and not just the goals of the research, but to think outside of that, like goals and motivations for all partners, including our patient partner here, Barbara, but also thinking about things like support and training. And so whether that be orientating to a project, any kind of support, but I think really strongly about creating the cultures for research that's really allows people to feel safe and to share their stories, and I think another thing was to be really prepared to follow a different direction, and that when you go into a partnership, you go in with that whole heart, that you say, okay, we will do an art project, even when I can't draw a damn thing. So and I think across the team too, and I can see some of the members of our team here, Damon and Shayna, and great supports, Rachel Wells from the north here too, and so many more to mention. And so I think that cultural the culture of safety within teams has been a huge learning opportunity, and something, that I think is super important. So I did have a few final questions. So I would ask the audience, we're kind of at like an open discussion time. And so if people do have questions, please jump in, and we'll be monitoring the chat box. But maybe we'll go back to Marilyn, and what are your perspectives on what makes those team environments feel most comfortable?
It's a really good question, and I wax poetically about my very first research group. I'm the lead on that team. I was so open. The Ministry of Health from both Quebec and BC were on this team. And so when she spoke and opened the first meeting, she said quite explicitly, every voice on this panel brings merit. And Erin reinforced this throughout that first year. Every time we met, whether in person or virtual, every voice. And so there are 4 patient partners, true from each province. She made us feel that we were of value, that we did have things to add, and we were comfortable doing that. The 2 from Quebec had a lot more experience. The 2 from BC were brand new to this, and they really have partnered with us to help our learning journey and get rid of any biases. I think that's one of the biggest things that you have to do as a patient partner, is set aside your own bias, but still to share your story. And so, Barbara, thank you for that, because there's so much to be learned from stories. But I think the biggest thing that a researcher can do is to just be open and share with the team that we bring as much value as those in government, clinicians, physicians, researchers. We're all rocking this boat together.
That's great. And
Marilyn, to that point, Davina put together a binder because I have to learn in very different ways now, and memory is an issue. So there was this whole lit review and study goals because my executive functioning was damaged. So she put together this process to help me, and I'm sure she was learning as she went along. How can I help Barbara? Because I didn't even know the questions to ask sometimes, because this platform is new. Like you said, you were new at one point. So when Davina put this together for me, it was so helpful, and the rest of the team found it helpful too, surprisingly. Yeah.
I wonder too, and Karen, feel free to jump in, and Marilyn, you mentioned this too around, you know, you had said in your reflection that you had learned about what the qualitative, quantitative and mixed methods mean. And so in this mysterious research world with all this jargon, and maybe Karen, you go first and just say, like, as a researcher, you know, what you found helpful to help kind of break down some of that kind of the language, the jargon, and then maybe Marilyn back as well.
Yeah, it's interesting, and particularly as English being my second language, language, I really like languages. I speak a couple of languages, but the jargon, hearing the jargon among professionals, hearing the jargon from researchers, speaking in very theoretical words, still speaking, you know, the language of the people, learning the language of working. I learned so much. Oh, Cindy's okay that I share her name. Cindy, I learned so much from you working with Indigenous and learning about ways of the two-ness, as I call it now, and worldviews. I grew up actually in two cultures myself, intergenerational, so I understand how misinterpretation can happen between language people from different countries. So I think what I found really for me was a turning point with the Patient Engagement and Research Committee was where I used the screen to start typing. I just started typing and following the conversation typing, and all of a sudden people, instead of perhaps gleaning from people talking, some members, they started to see the text on the screen and they started to engage more. And that for me was the realization that people, when they started, I remember somebody saying, I just all of a sudden see my name and I contributed to the conversation, where if it would have just been auditory, the person might not have felt being heard. Whereas when I was typing, it was something very awkward for me to realize that all of a sudden the person could see that I was saying so-and-so was saying this. And the documents are always confidential. We have confidentiality agreements and maintain confidentiality. We're not recording the sessions because just to really ensure that safe space. Does that answer your question a bit, Davina?
Yeah, that's great. I'm just going to encourage the audience to, like, feel free to jump in if you have experienced any barriers or things that have helped as you've navigated those partnerships. We'd love to hear. Jump in with some questions, and Marilyn, maybe we'll go back over to you too, and to think when you were talking about kind of learning the lingo and all of that, like what was that like for you? I'm curious.
It still can be a challenge in a new group, excuse me, particularly. You know, first of all, Davina, kudos to you for putting together a binder for it, because we're not all auditory learners, as Karen has mentioned. We do. Some of us need to see things written down and have a hard copy. So that is a huge elimination of a barrier. I think that really having a glossary to refer to is extremely helpful. And I've used a couple of acronyms this morning, PICKY, MRF. If you asked me what they mean, I'd have to go to my little notebook and say, oh, here it is. This is what it actually means. And so I think even using the acronym of POUR, you know, to some people, what do you mean? Am I poor? I mean patient-oriented research. So I think even as patient partners, as we grow through this journey, we always have to be mindful of language, and not necessarily cultural language, but that language that comes from research and helping others on the team to really understand. So glossaries are absolutely valuable.
That's great. We also found, I think, something that was useful was a team manifesto, where we really kind of put our values together as a kind of a guide mark of how, whether that would be things like, providing information in advance so that everybody had enough time to review, or again, like recognizing, that no one voice is more privileged than another. And what else do we have? We had lots, didn't we? But we actually used Clay Hamilton's peer framework to guide our conversations, and it was super helpful. And so our manifesto has been something that we've held near and dear and frequently go back to.
And that manifesto helped me feel safe to be vulnerable. So that's the most important thing. If a patient can't, like the acronyms, as you mentioned, Marilyn, if all of this language is going on and the exclusion is going on, and I learned through this team manifesto that everybody's voice was valuable, that no one person was more important than the other, and that we all had input, and that it was accepted. So I learned that I could ask questions. I've been in other organizations that had, this is not unique to research. Acronyms can be, can make people feel that they're not included anywhere. So to just even to remember that. And I had the ability to talk to every one of these people. And some of them scared me, and I told them that. I remember telling one of the researchers, I said, "You scare me." And I laughed, because I have to do it that way. And that's the important thing. And then if I felt excluded by a researcher, I just thought, okay, move on, and so I learned a lot, but I had a voice before. So I remembered how important voices are. And I think that that's what you're explaining too, is it is so important when somebody's voice is not heard, that space be given to that. And I look forward, I'm still brain injured, but as I learn through this, I'm hoping that people get better treatment for strokes, especially living in the North. Yeah,
Sure.
yes.
This was one of the art projects that we did. And this is the disco fish, and this was my disco fish, because I always consider myself mostly ridiculous. So there's this is me embracing who I am in our research. But we all had I just spotted it, but there's our little disco fish there.
And
you all.
And that was part of the art project at the brain injured group. And we had 18 people who are not artists come together, and we got to tell our story through work and actually inform ourselves of our journey too. It helped so much. My fish is Jonah the whale spitting me out, because I was going in one direction in my life and I didn't realize. That's when I realized that my life is now in a new direction. I'm now a patient. I'm not on the other side. So that art therapy is so important, and sharing with the team doing it too, and then watching people just grow into their story and their experience, which helped frame all of what we got to talk about in the research.
Okay, I'm seeing so we have probably only time for one last quick question before we wrap up. And so Amanda asked as well about the close relationship between researcher and patients, and the impact of balancing that kind of ethical and potentially biased nature of working so closely with patients, and the complexity of engaging in probably rigorous patient-oriented research piece. And so I'll hand that one over to Karen as our final comment, and then we'll wrap up.
Thank you, and I think that is actually an amazing, wonderful question. I'm so glad it comes forth out of this discussion. I want to thank you all, because I really think that one of the things I really learned is about the, I call it the anesthetics or the aesthetics of the dialogue, of the interaction, the ethics of being in relationship with each other and ensuring the well-being of each other when we're in conversation with each other, not only your own, but also of the other who you're speaking with. And I really want to thank you for your time together today.
And Karen, if I can just very quickly add, the researcher needs to check in after every meeting with the patient partner to make sure they understand, to make sure they, caught the lingo and how they're doing with the process. Thank you.
Thank you.
Right. Yeah. And so we're at our final minute. And so we thank you so much for joining us. And Larry, thank you for being there too. And I don't know if you have any extra messages, but thank you so much on behalf of all of us. Some great questions. Absolutely loved having you all here. Larry.
Well, thank you very much, Davina, for moderating today's panel. Thank you for the panelists. On behalf of everybody at the support unit and all of our attendees, thank you so much for this excellent presentation. I'd just like to remind you now that we're entering into our lunch break / poster sessions. So please go and see your favorite posters when you want to during this next hour and a half. But then please rejoin us in the main room at 1 p.m. for our panel presentation on LGBTQ plus engagement in patient-oriented research. And that's at 1 o'clock. So thank you very much, and we'll see you all soon.